Okay, we're going to go ahead and get started with the afternoon. And go ahead and settle down, and we'll go ahead. Thank you, Ziad. Yoo-hoo. All right. So this is like a rowdy crowd. This has been fun. I guess when you talk about opioids, you know. So this morning was really, in many ways, very clinical, and really from the perspective very much of, sort of on the ground with patients and with clinicians and struggling with all the various issues that we talked about in incredibly rich and wonderful conversations. And for this afternoon, we're going to shift to a little bit of a higher level. And this next panel is going to be on sort of how regulations kind of play in. And then the very last panel of the day we'll get to will be sort of looking towards solutions. So we're really thrilled to have three superb people that will be speaking to us today. So what I'm going to do is I'm going to introduce all three of them right now, and then they'll each come up and give talks, and we should have a good amount of time at the end to talk among ourselves. So our first speaker is going to be Hemi Tewarson, who is the director of the Health Division of the National Governors Association, which has been doing work at sort of thinking about state legislative policy around this issue. Our second speaker is Michael Botticelli, who's the executive director of the Graken Center for Addiction Medicine at Boston Medical Center, and in that role, it's an extraordinary center that does fabulous work in this area. He's here, though, really in his role as the former director of National Drug Control Policy. And he's able to speak to us from the federal perspective of how past federal perspective clarified there for how the sausage gets made. And finally, Trent Haywood is the Senior Vice President and Chief Medical Officer, Office of Clinical Affairs for the Blue Cross Blue Shield Association. And Dr. Haywood is able to speak to us really from the perspective of the payers. So we'll just go ahead and hear what they have to say.
Is there a clicker?
There is a clicker.
Yes.
You push the green button.
This one right here.
I think it's one.
This one. Okay. Great. I'm a little shorter, so I'm going to adjust this. Really happy to be with you all here today. I was here for the morning sessions, and it was, I think, always great to hear the patient perspective and the clinician perspective that's really coming from the ground. I mean, where I work, I'll tell you a little about the National Governors Association in case you're not familiar. We are a bipartisan organization that represents all governors, Democratic and Republican. And where I work is the Center for Best Practices, which is really a think tank consultancy supporting governors and their healthcare leaders to think about what are policy strategies that they need to actually move forward to address their top concerns. So I'm here and speaking from my experiences working at the center with states and their senior leaders and governors, and I don't represent any particular perspective of a governor. So I wanted to make that clarification right up front. But the reason I'm here today is because opioids really has been a top priority, unfortunately, for governors since 2012 for us. That's when we started our work on this, and we now have, I think it's a 7-person team who focuses a lot of their time on this, for lack of a better word, crisis/epidemic. So wanted to talk just a little bit about where we are. And we had a great presentation, I thought, earlier today about what is happening with opioids and other substances in terms of death. And this is a map from 2015. I have one that's 2016, which is, I think, showing where you see the pockets where the numbers of deaths have risen very significantly across the country. And I say that because this is the type of data that the governors get when they come into office, and it's an interesting time right now. We just had elections. We have 22 new governors, including the territories, almost half the country. They have a lot of great priorities, and we just had their seminar for new governors last week, where they got together and to talk about how to work with their cabinets and think about where to move forward. And, a lot of them want to work on things like education and addressing sort of cost curve in healthcare. But this is going to be presented to them as a challenge in their state. There's no question about it. We just saw the CDC reports that were released, which I don't think were mentioned earlier today. So there has been a decline in life expectancy by 0.1% from last year, which is never good news, is making headlines as usual. Americans born in 2017 are now expected to live 78.6 years, which is a decrease from last year. Unlike the other developed countries in Europe, we are going in a different direction. More than 70,000 people died of a drug overdose in 2017, the highest number on record, unfortunately, a 9.6% increase from 2016. So this is not good news, and this is what's going to hit these leaders when they come into office, some of them December, most of them in January. Overdose deaths involving fentanyl and certain other synthetic opioids increased 45%. And suicide is also a contributor, went up 3.7% in 1 year. So, the deaths of despair that we talked about earlier today is certainly continuing to show in the numbers that we're seeing, at least from the CDC reports. One of the interesting things about that report is there was an uptick in deaths for ages 25 to 34. And a slight decrease for 45 to 54, which is interesting. And I think that's why this particular, it has such a big impact on the life expectancy, because it's hitting the younger people. And that's why when you see the curve, that's why it has such an impact. So with that good news, I'll keep moving forward. We saw this slide earlier today, so I won't spend much time on it. Certainly, we're not just talking about opioids. There's the synthetic opioids. There's, heroin is also there certainly is, you can see with the curve, a really high increase at the top line with the synthetic opioids, other than methadone, which continues to, I think, challenge folks. And I will tell you from a governor's perspective, they feel very frustrated. They have, what could be called as fairly blunt instruments to try to address the problem. But the death numbers continue to go up. So, I think the question is what comes next. I thought there was a lot of great discussion earlier today about the different considerations and the impact and, frankly, unintended consequences for people with serious illness, and need of palliative care, which, I think from a policymaker standpoint, my perspective working with them, that's not the intended consequence. It's not to sort of take away solutions for pain for people who have cancer and need palliative care, but it is, I think, certainly something that sounds like from you all's experience, a byproduct of what's trying to happen on the prevention side and trying to address the deaths. So I'm here today to talk a little bit about what we're doing at NGA in our work on the center side, to think about how states can be strategic and really try to move the needle on this, because there is a great interest to try to help. Governors and their staff hear from families every day about what's happened with their loved ones and the impact of the deaths, and can they bring solutions? And it's a very strong message, and the legislators hear them as well. I don't represent the legislators, but they certainly are very active in this space as well. So just a little bit of background on what we've done. We, as I said, have been working on this since 2012. This is not a new issue for us. We released a roadmap, if anyone's interested, in 2016 about not just opioids, but also heroin, and how to think about strategies. And really what we emphasize for state leaders is, assess your current capacity. What is it you can do? What are the evidence-based and promising practices that you can deploy, and then evaluate what the impact is. And I thought we had some really good comments earlier about thinking about not just looking at, is there a reduction in the number of deaths, is there a reduction in the number of scripts, but also patient outcomes. And that's certainly something that we talk about from the Center for Best Practices perspective. How are the individuals actually faring with some of these changes? One thing I did want to mention, there was a real interest from governors to actually do work on this. And in July 2017, they actually signed a compact saying that we are all going to work on this. It's really, we don't often do that, have them sign on a big compact like that. They did. It was, I think, the first time we've done that in 10 years, because there was a sort of across the board interest in, like, we need to do something. We need to be part of the solution. States can't solve it on their own, but they certainly need to be sort of leading and partnering with others in their state to try to help. In 2017, governors reported back on their progress as a result of signing the compact. And I just wanted to highlight sort of two examples in case that's of interest to you. Governor Walker in Alaska issued a public health disaster declaration, which authorized the Department of Health and Social Services to issue a medical standing order that allows community groups, law enforcement, and members of the public to dispense and administer naloxone. So that was one example of a very concrete thing that they wanted to make sure that naloxone could get out to try to help address people who were having overdoses and try to save their lives. Another example across the country was at the time, Governor Christie from New Jersey. He called for and signed legislation requiring health insurers to cover immediate access to treatment for substance use disorder, including inpatient, outpatient, and MAT for up to 6 months, which made New Jersey the only state at the time to guarantee coverage. So those are examples of, where governors try to take action in a way to try to then allow sort of the community level, law enforcement, other folks to be able to provide more access to treatment for individuals with this disorder. Okay, next slide. There's a lot of things that they've been doing, and I think, I could take a whole hour talking about all of that, so I won't talk about all that, but just to simplify it in sort of buckets, there's certainly the actions that, and I think a little bit of this was talked about earlier today, reducing the flow of prescriptions. So a lot of sort of coalescing around limiting first-time opioid prescriptions, and I'll talk a little bit about that on the next slide. Promoting clinical guidelines and safe prescribing. I think we all talked about the CDC guidelines earlier today, and perhaps not always being true to the CDC guidelines in practice. Transforming pain management, which that is, some states are really trying to support and enhance community-based collaboration, really trying to be the conveners, bringing together law enforcement and health officials, and then also bringing sort of local community providers together and stakeholdering and having someone lead that charge to really try to bring, for lack of a better term, silos together to talk about this, because it's not just a health issue, obviously. Law enforcement plays a huge role, and so does other community service supports. So how do you bring those pieces together to really more holistically address this? Increasing non-opioid treatment benefits. I'm going to talk a little bit about that. We're doing specific work around that. I think we heard earlier today, sometimes the plans don't cover it, and we can hear more from Blue Cross Blue Shield directly about their perspective on that. Enhancing access to medication-assisted treatment. Some Medicaid programs didn't cover methadone, for example. So, really educating and trying to understand kind of the benefits of having more access to MAT is really important. One thing we're really actually going to look at in 2019 is corrections populations, for example, getting MAT in the jails, but then also making sure that they get treatment when they are actually released, which is, I think, a really critical part of the equation. And building the workforce. So, we've heard from states, and I think we heard from the last presentation that there are not enough buprenorphine waiver docs who actually feel comfortable prescribing. There are also primary care doctors out in rural areas who feel isolated and may not feel like they have the training, and maybe not even just rural areas, other areas where there just is a lack of being comfortable with, I have a patient who's really complex, has a lot of different comorbidities, but they also have SUD, and I don't have the training to address that. So how do we think about helping the workforce, and how from a state level can we help support that? Okay. I'm going to keep going because I only have 4 minutes. So I just wanted to touch briefly on this because it was talked about earlier. So there's certainly state prescribing policies, as I mentioned, more of a blunt instrument where 15 states have set 7-day prescription limits. This is most common. This is what follows the CDC 2016 guidelines. 4 states have set 3 to 4 day prescription limits. This is more rare. And I think only around 4 states have set dosage limits. And I think, in all of these cases, there's these exceptions for people with chronic pain treatment, cancer, and palliative care. And I think it sounded like from the discussion earlier today, sometimes in practice that's not actually, fully embraced. And there's concerns on the part of providers of how to apply those exceptions. But that's the intent. And really, a lot of these script limits are around acute pain presentations as opposed to sort of the more chronic pain challenges that people are facing. Now, I'm not representing the state legislator folks, but we did a scan, and across 45 states there are 480 bills on this. So this is a topic that's going to continue to have movement at the state legislative level, and of course the governor's offices have involvement as well. Okay. Yep. There we go. So I want to just talk really quickly about some things that we have done, just to give you some really concrete examples of the work we've done with states. And a couple of them, you can see it's across a lot of different areas we've really tried to tackle. Really, what is the best practice, and sometimes there isn't, but what are the promising practices under each of these areas, and how do we have states learn from one another and from, community providers and other providers and health plans. So one of the things I wanted to focus on is number 3, improving access to addiction treatment in rural areas. So in that project, we highlighted Project Echo in New Mexico, where they have, I think, a really impressive ability. New Mexico does not have a lot of behavioral health capacity. There's a lot of primary care providers that are faced with very complex patients, and they don't have a big bench to support them. So Project Echo is a key way that they help actually get that expertise that is housed in the University of New Mexico out to areas where they don't have the access to addiction specialists, psychologists, psychiatrists, all these other sort of support services. We brought other states to learn about it, and the states are setting up Project Echo, models in their own states. And I think from a workforce perspective, that's one that I think is going to have more traction looking forward, because there are areas where we're just going to not have enough providers to really help address the addiction crisis. Another one, area 4, medication-assisted treatment for justice-involved populations. I talked a little bit about that already. Massachusetts was our model state for that, and we brought other states to learn about that. They, through their drug courts, have a sort of long-standing commitment to providing MAT for corrections populations, and they do a pretty good job of then trying to get those correction populations. They're an expansion state, so those people are on Medicaid when they come out, to connect them to services when they come out. So that is something that we're going to continue to sort of share best practices with states in 2019. So I wanted to highlight that for you. Number 6, neonatal absence syndrome, although I heard in the first presentation I shouldn't use the word syndrome, where we highlighted Ohio as our model state. Because they have a program called Moms, where they really provide more holistic care for pregnant women to try to reduce the number of babies born with NAS. We brought other states to learn about it. Certainly a topic that is of interest to the White House and HHS. So we will continue to, I think, promote that model and really help states learn more about how to implement that. Frankly, from a state perspective, in certain states it's a challenge, because there's still some laws on the books that endanger the mother to lose the child if she comes forward with an addiction. So more work needs to be done on that. There are some states we talked to, like, we set up these programs and they don't come. It's like, well, because they're afraid of losing their child. So there's a lot of stigma associated with it. So we will continue to do work on that. And then I know I'm running out of time, so I'll be very quick. Number 8, I did want to talk just briefly about this non-opioid pain management. So we recognize that there has to be, I got the light. I'll go quickly. There has to be some solutions for people with chronic pain in non-opioid space, and I think we talked a little about the coverage policies. So I just set up some examples here where we had a roundtable where we brought people together, all states, industry, experts, to talk about, like, what is a solution here. We're going to come out with a paper on this for state leaders primarily, but of course anyone else that is interested, to really talk about what are solutions in that. Where can the coverage policies go? What should they look like? Just for 2 quick examples. In Ohio, Ohio decided, okay, we are going to allow the coverage of new services such as acupuncture that are provided by licensed practitioners, and they've since broadened the rules to cover the practice when performed by licensed acupuncturists. So that's an effort of trying to expand Medicaid coverage policy to try to address sort of other options for people who have pain. And then lastly, I'll talk about South Dakota, which is a state that probably doesn't come up that much because it's a small state, but they wanted to increase access to non-opioid therapies and Medicaid through a health home, really having a centralized location where there could be a lot of different services provided to individuals. And they were targeting musculoskeletal conditions among those qualifying chronic conditions for the program participation, and they found some savings. But really the point of that is, how do you bring together care management, care coordination, health promotion, transitional care, recipient family support services, and referrals all in one place? I mean, that's, I think, currently what's somewhat missing in our system. So, these are just examples of what states are trying to do to give you a flavor of where they're going. So my last takeaway, then I'll stop talking, I promise, is really thinking about, it's so good to hear from you all who talked earlier about like the exceptions and how the exceptions may not actually be working in the way that they were intended for people with cancer and other serious illness. Pain management, really thinking about a more holistic way of thinking about pain, not necessarily you can't have opioids or otherwise you have to do massage therapy, but really thinking about it in a holistic way and how it all fits together in a continuum of care. And then finally, education. I think really allowing providers and figuring out how states can support this to have more access to addiction specialty, whether they themselves get better training, they get better access to training. There's certain areas I think that is really a gap. So we will continue to think about that from the NGA. So thank you very much. Oh, yeah.